Welcome to the IFSO podcast. This podcast is sponsored by WakeWorks Clinics, the Netherlands.
Welcome to a very special third IFSO European chapter podcast. My name is Sjaak Pauwels. I'm a surgeon in training, originally from the Netherlands, but now working in Herne in Germany. And I have two guests now, both nutritionists, one from Switzerland, one from Israel. The first one is Laura Vaccarino. Laura, welcome.
Hi, nice to meet you. Nice to be here.
And the second one is Jafit Kessler from Israel.
Hello, thank you for having me.
We are going to talk about key nutritional rules for bariatric and metabolic surgery. A topic we can talk for hours. What we'll do in the next 30 minutes, we'll walk through the most important steps. From a surgical point of view, surgical techniques can differ, but nutritional assessments prior and post-operatively will always be the same. I've got two guests, two from different parts of the planet. Laura, I would like to ask you, what is your normal nutritional assessment before bariatric surgery and afterwards?
So for sure, we will see the patients at least 1 to 2 times to get to know the patients, and then we will work already before the operation about the habits of the patients. We will try to improve the knowledge about anti-nutrition, and we already teach the patients how it will be after the operation with the new habits, that he can already start before the operation with eating slowly, chewing well, eating the right amount of protein, and eating the right amount of meal, like a training before the operation. And I always do a very good experience because the patient, they are then happy because there is no surprise after the operation if they are very good informed.
Mm-hmm. Yeah, that's something I can refer to in terms of the more well-informed patients are, the better results we'll get in terms of compliance. What can they accept? We'll go to the other side of the globe. Jafit, what is your experience? How do you assess your patients from a nutritional point of view before and after bariatric surgery?
Well, what we do is between 3 to 6 meetings with the patients before the surgery. And this is divided to the patient assessment and then patient education. We want to give them the most information about the surgery before they do it. And after that, we want them to practice and come prepared to the surgery. We also look at their nutritional status and we see if there are any nutritional deficiencies that have to be adjusted before the surgery by supplementations. And we want to see how patients understand what they're going to go through, how prepared they are, and what are their expectations about the surgery, if they're realistic or not. And mostly we want to get them to the surgery in a good state of mind, both physically and mentally, because they have a long way to go after the surgery.
Yeah, I totally agree. Normally it's a trajectory. It's a life-changing event, bariatric surgery. But from my point of view, the surgery is only a tool, a means to an end. All the surrounding factors, like nutrition, like psychology, like exercise, even family relations and the social aspect needs to be in order to get the most optimal results. And you both say, okay, we assess the patients in specific time points before and after bariatric surgery for a specific amount of meetings. But just to be very honest, the psychologist does exactly the same the physiotherapist also does exactly the same. So that's a lot of information for patients that are scheduled or thinking of bariatric surgery. Laura, can you tell me what is your trick, your tip? How can you make this information in somewhat way condensed, so a short form information that patients really get it, that patients really remember it, that they know what you're talking about and that they understand you?
I think the key is that when we do the consultation with the patient is always a kind of discussion. It's not just that we are talking and the patient have to sitting in our room and just keeping the information. It's really working together. That means that they are very active in the consultation. Our patients, they have to give not only answer, but they have to reflect about their nutrition habits. And then I push my patient to ask question and not only to just to sit there and okay, give me all the information. And what also I think it's very important is to give the patient something written, that they can read the information at home. They can continue to inform ourselves. And what I always do during the consultation is not only to give something that is already done and written down, but I say to my patient, okay, this is a paper, please. You have to write down which keys, which are the very important information that you are taking home. And then through that, I can see if the patient, they really understand what we are talking about. And if I see, okay, the patient that cannot write down the key message, then I know that my job is not done and the patient is not ready for the surgery.
Okay, but okay, this is a very structured way of working, a way of preparing patients for surgery. In terms of making it more practical, how many hours does that take normally?
So usually, the consultation, the first consultation is always like 45 minutes, and the following consultation, we always do like 30 minutes, because I know that after 30 minutes, the patient have no concentration anymore to be able to keep the information. And then in between the appointment, we plan always like a call discussion that I call the patient at home, and then it's like 10-15 minutes, and we really try to spread it out the contact with the patients.
Okay, so to keep it more condensed, to keep it more chewable, basically, the information you spread it out just to get the learning effect of getting the information from you as a nutritionist. Okay, well, we'll hop on to Yafit. Yafit, you've heard Laura's protocol. Do you do exactly the same, or does it have any differences? What's your point of view? How can you prepare patients in a more structured way?
Well, I think most of us have a similar protocol, which is a good thing because this is how we work in medicine and we want to give all patients the same knowledge. But there's also the personal touch and also, of course, what the patients bring with them. So what I try to do in order for the patient to really be able to take this information before the surgery, because they're really waiting for the life after, is to take this to daily experiences. For example, to go home and when you have a family dinner, imagine now you can only eat between 3 to 4 spoons and that's it. You're full. There's still a long dinner to go and you have to sit there with your family or friends and you cannot continue eating. I think it's a very tough experience. It would be also tough for me as a person. I mean, I can really understand that there's a lot of give and take. When you decide to do the surgery, you're going to sacrifice some of your enjoyments in life in order to get maybe better health, maybe more years of life, maybe a better quality of life. But it's really important to feel on your body and in daily experiences and in inter-people experiences how this is going to be and how you're going to act.
So you're already implementing the social aspect I had just spoken of a few seconds ago. Like, what do you do when you only can eat a small amount? And do you then have one-on-one consultation with patients, or are there family members present during that consultation?
Well, mostly people come for one-on-one consultation, but I do encourage them to bring the main spouse or maybe like a family member if they still live with their father or mother, because as you've said when we began, this affects the environment and the social environment. And people from outside have a tough time understanding how it can be that the person that used to eat in a certain way will now eat 180 degrees differently. And so there are a lot of questions and a lot of even nagging questions. Why you're not eating this? Why are you eating this? Maybe you shouldn't eat this. So I do think that maybe bringing someone with you to the consultation has a big advantage and will help patients overcome the first months of the surgery in a better way and with more support, which is really important.
Because the reason why I'm asking to involve other significant others, family members, that's a concept I've seen in the Netherlands, particularly in Eindhoven, one of the bariatric surgical centers I worked, so-called group therapy. That a nutritionist or a psychologist goes through the important nutritional or psychological aspects in case of a psychologist with patients before or after bariatric surgery. First of all, Laura, do you have such a concept back in Switzerland? And what's your opinion on group therapy?
Mm-hmm. Also, big center in Switzerland, they do groups therapy before and after the operation with very, very good experience. It's a very good opportunity for the patient to talk with other patients in the same situations and people that are not feeling alone, or they cannot say, okay, I'm not the only one having this kind of problem. And then we can try in a group. It's really very good dynamic to help each other. So yes, we do that in Switzerland. We also do like not only a therapy consultation, we also do like cooking classes with patients after the operations. Just to teach them how big is the portion, because one of the things that they always happen straight after the operation, they still buy the same amount of food as before the operation. They still cook the same amount with the risk that they have to vomiting because they are not able to stop themselves. That's why we try not only to do group therapy or individual therapy, but also something practical with cooking classes.
So basically, I would, if I understand you correctly, a group therapy is more from a practical point of view in terms of cooking, in terms of what to cook, what not to buy, what to buy, in terms of food, in terms of other stuff. Okay. That's really, really interesting. Do you use the IFSO cookbook?
Yes, and we wanted actually to join, but we skipped the deadline. But It's great. It's a very good idea. Absolutely.
Spoiler alert for the editors. We need a volume 2. Fried, group therapy, a concept known in Israel, or is it not present at all?
Yes, we do have group therapy. It's mostly done with both the dietitian and a social worker or psychologist. And it's mostly done actually after the surgery and less before. I think that it is very good for the patients because what they're looking for is a group of equals, someone who is going through what I'm going through and can understand me and relate to me. And sometimes this is a barrier between the character who's taking care of you, whether it's the doctor, the surgeon, the dietitian, because maybe the dietitian is too thin and then she can't understand me, or the surgeon didn't have the surgery on himself, so he doesn't know how I'm feeling and where my pain is. And they're really thirsty for people who are like them, can relate to how they feel. And this gives them a lot of power because they also look at at each other. You know, they say that a group is a hall of mirrors. And when someone speaks, I feel myself speaking through him. And if he's going through this, then it's normalizing what I'm feeling. So it has a very strong effect. And I'm very pro these groups. And in general, I think that this has to be a multidisciplinary care.
I think so too. I've had similar experiences among the centers I worked in Eindhoven, and group therapy really helps. But in my opinion, it needs to be structured, because otherwise, a group of people will start talking, and there will be no benefit in terms of health, in terms of practical issues, and so on. Okay, we're along the way in terms of the treatment of obesity. We're scheduled for bariatric surgery, and then the phase comes that patients have their liquid diet to shrink their liver volume. And a few things I've heard in the past, that it's a drastic change in caloric intake, a drastic change like how they need to eat. It's only liquids. Laura, how do you have any preparation in your nutritional preoperative assessment for this phase before surgery?
As before surgery, in some situation, in discussion with the surgeon, we do not a liquid diet. We do a very low carb diet for 2 weeks. Because of the liver, to reduce the size of the liver. And for us, it's also a very good opportunity to have a look about the motivation if the patient, if he has or she has to follow strictly some rules, what's happened. And usually, exactly, we do like 2 weeks, very low carb diet before the operation, but not in a liquid form or with prep meal or with supplement, special supplement. What we put some attention, we already gives multivitamin before the operation during this very low carb diet, and according to the laboratory value, we adjust if there is some other deficiency.
You're already addressing a few of the topics I want to talk about in a minute, but this is an interesting point you're mentioning, because a liquid diet or very low carbohydrate diet is a drastic change, but it's also a testing point of motivation of a patient for surgery, and in general their life-changing treatment. What happens if they don't succeed their liquid diet?
Actually, it's like this. During these 2 weeks, we really see the patient very, very regularly, like twice a week, in our office or through the phone. And we really try to motivate the patient. And if they cannot, then we talk about that in our multi-professional team. And sometimes we have to say, okay, maybe it's not the right moment for the operation, and we postpone the date of the surgery.
Okay, that sounds logical, but 2 questions arise when I hear your answer. When it's not the right point, when people are lacking motivation or having trouble continuing a very liquid diet or a very low calorie diet, okay, they do not get the surgery right now. What happens afterwards?
Yeah, usually we involve our psychologist team and our clinical nurse, and we really try to figure out what's the problem. Is something, for example, we really have a look about everything. Is something social? Is something with the family? Is something psychological? Is something, it's the fear of the patient? Sometimes it can also happen that the patient, they want, but they don't want to do the operation because they are afraid what's happened afterwards. As the colleague said, that they cannot eat as before. And for some patients, it's really, really difficult to do that.
So basically, this is a luxating factor for a deeper lying psychological problem in terms of anxiety and so on. Yafit, you've heard the experience of your colleague in terms of liquid diet, in terms of protocol, in terms of basically a pivotal moment, like can patients go further with the surgery, or if this is not the moment, what happens afterwards? What's your experience in this particular phase before surgery?
I think we have a bit of a different approach. First of all, we do not use the liquid diets before the surgery. Our protocol is to go to the low calorie, low carb diets. We usually do them for 2 to 3 weeks before the surgery. And we want patients to adhere to these diets, of course. But this may not necessarily be something that will decide if they can or cannot do the surgery. If the patient will come after this diet and he has an elevation in his weight, this may mean that maybe he had a hard time, and then we will refer him or her to have more meetings with the dietitian. So it's not you cannot do the surgery, it's maybe you need more help. So this help can be behavioral with a dietitian or a psychologic, or this may have a need of stronger help, for example, to use pharmacotherapy as a bridge of weight loss if the patient is with a very high obesity rate and it is a very high risk to enter the surgery now and he cannot lose weight by himself. So pharmacotherapy is also an option. And I think that mainly we know that long-term motivation is not like a big thing that you can decide upon if the patient is able or not able, because most people can arrange a short-term motivation. We know this from diets. They're a short-term product. But the big question is about the long-term motivation. So most people are able to eat less for 2 weeks, and sometimes metabolically their body does not react to it, and they do need help. But I think the motivation to go through the surgery usually helps them to overgo these 2 weeks. And we do not use the liquid diet. So maybe this also helps them because they do get to chew real food.
So basically your approach is a bit different than Laura's. And your approach is not canceling the surgery, but giving extra help to complete a goal, if I understand correctly.
Yes, I think that the contraindications for the surgery are actually the mental ones. Like if there are mental issues which are not balanced and not treated, or if there are eating disorders or any medical things that are supposed to prevent the surgery. But if the patient is having a hard time losing weight, this is the reason he came to the surgery and he came to us for help. So we do not want to turn our backs on him, and we will try to stay and help, of course. And I'm sure that this is what you're doing.
Absolutely. Yes, absolutely. And I think what is also important to say, as you mentioned, the patient, they are motivated. And I really, in my career, we just have to cancel once an operation. But I was happy we did that because we found it out very, very severe psychiatric problem in these patients. Yeah. And as the colleague said, it's very important to give the help. It's a multi-professional approach for these patients. And nutrition is one point, psychologist is one point, the surgeon, the physical activity as well. We try to already motivate the patients as they can with our physiotherapy team already to introduce. And if the patient, they notice that we are not against. We want to help the patient. We want to do the best. And in the most of the cases, everything is fine.
It's basically fine tuning so that people can succeed through treatment. Oh, that's something I really appreciate. Okay, well, we extensively talked about the preoperative period. Let's go to the post-operative period. Partly also in the preoperative period in terms of vitamins, minerals, and deficiencies. In my experience, you need to do a lot of lab work, preoperatively, postoperatively. And one of the arguments I often hear is, especially from colleagues from smaller clinics, like, yeah, it's very costly, it's very, very expensive to check everything, and some deficiencies might not be clinically as relevant as others. One of them could be a zinc deficiency, which causes hair loss. In a male patient who is almost bald, that has a different impact than a young woman with very nice blonde hair if she loses hair. So from that point of view, what do you think? Do we need to basically check everything, preoperative and postoperative, in terms of vitamins, minerals, etc.? Or do you believe in a more structured and tailored approach? Laura, I want to ask you first. What do you think?
So what is very important to say is that in our clinic, we do the post-operative consultation together with the internist. So we are physically the doctor, the dietitian, and the patient in the same room. And this is a very big advantage for the internist, because we as a dietitian, we can really do a very, very good nutrition assessment. We really ask the patient to do a protocol, to take a picture of the meal. And then we can try to figure out through a very good nutrition assessment if there is a chance that the patient has some deficiency. And then can the doctor decide, okay, maybe we need to do a bigger control. And if we notice, okay, no, actually the patient is doing well, there is no problem, no vomiting, no big symptoms or problem, then we go for a small control, and we try to do that, not try to reduce the frequency, because, I mean, cost is a point. I mean, we cannot just close our eyes and say, no, there is no cost problem. So we really try to be pragmatic and to work in synergy, and doing as good as possible a nutrition assessment with the patients. And usually straight after the operation, the patients are very, very motivated. They really came with with picture of the meal. They take the supplements. The problem is 2, 3, 4 years after the operation, because then the deficiency can really be there, because patients don't take anymore every day the vitamin. The nutrition habits, they are maybe not so strictly as after the operation. So the first 2 years after the operation, usually we are not really worried about our patient. They are even in better hand than people without surgery, because they are strict in control.
You address a few interesting points, because what I really like, and that's not the case in every bariatric surgical clinic, is the combined consultation with the internist. Is that also the case preoperatively, or are you consulting separately then?
Preoperative, it depends if they have medication to lose weight, and we do together, and it's very individually. But after the operation is fixed in our program, that we see in the first years at least twice together with the internist, and sometimes even more. And this is for everyone is a very good thing, because on one end, our patient, they work. They cannot come regular. They cannot afford to always take free from the job. And then they are very happy if we say, okay, you just come once and you have both you have doctor and nutritionist. And what is also very good is really like a kind of discussion, and there is no problem about misunderstanding what the nutrition said or the patient can say, but the doctor said that, and the nutrition said that and that. And we really have a very, very good experience. And we also, the internists, they always say to us, they learn a lot about nutrition with us. And for us as a nutritionist, we learn a lot about the medical point of view after the surgery. So it's a win-win situation for everyone.
I think so too. Second point you addressed is that you basically, there's an interplay between the nutritionist and the internist, like what kind of lab work do we need to do? And then you pointed out, okay, if there are no symptoms, we might do a smaller lab work, and if there are symptoms, we need to extend our lab work, what we need to check. What do you think about the patients who have deep deficiencies, for example, vitamin B12, with no symptoms? Because that's a tricky one, and vitamin B12 is just one example. How do you check that?
When I say that we go for a small control, then we control the parameter that we know they are at high risk to be low.
Yeah. So though you always have those tricky deficiencies in the back of your head. Okay, good. David, you heard a lot of experience from the Swiss side of things. Do you agree? Do you have another point of view? What's your lab work like in Israel?
Well, I can share what we do in Israel. We ask for the lab tests and we integrate them with the nutritional interview. I think the question is, what are we going to do? Are we going to do prevention, or are we going to do treatment? And because we want to do prevention, then we will want to do the whole blood tests always as the routine tests, which are in the first year every 3 months, the second year every 6 months, and then from the third year annually. And the reason is that prevention will always be cheaper than treatments. So I will prefer to do all the blood tests and then integrate them with whatever the patient is eating. And I will give the vitamins and minerals accordingly to the results. And sometimes it will be to elevate deficiencies, and sometimes it will only be to preserve because the tests are good.
Okay. So you have basically the same point of view, but you have the opinion that prevention is better than treatment, and yeah, some people agree, some people disagree, and let's say it this way, that the truth might be in the middle in this case. You both already pointed out that you're nutritionists, both in different countries, and we've heard different protocols, different opinions. But what I find very interesting is that you are also assisting the psychologist in terms of eating behavior, in terms of what do you need to expect, what do you need to do in social situations. But you're also focused on exercise, on what to eat, what not to eat. Laura, how is that? You're as a nutritionist, you're I say a beacon in integrated health, basically, of course, together with the rest of the specialties. How is the collaboration in your center with the physiotherapists, with the psychologist? How do you guys collaborate to get the optimal results for your patients?
So actually, we have a regular meeting, board that we discuss patient situation, that we discuss protocol, that we discuss what we can improve. And this, for me, is the key. Really talk together. And it is also the reason why we decided to do this consultation together with the internist, because we know that we have to work as a team. And if the patient, they experience that and they can feel in that, they trust us. And they are also very open to discuss question or to discuss topic that they are not so easy to talk about that. And that's why I think it's very, very important to have this synergy and this multi-professional approach to our patients. And as you said, we play sometimes a key roles through the therapy, because we are the figure, or the medical figure that always have the more contact with the patients, and they always call us if they have any question, even if it's not a question about nutrition. And then we can say to the patient, okay, now it's more about physical activity. I will give you to my colleagues. And then they notice, okay, you are really working together.
Is that synergy the same in Israel?
Yes, actually, in Israel, we have a second degree that's called Nutritional and Behavior, because these two terms so interact with each other. It's only natural. And I think it's very important to work together. And also it's very important for every professional to have his own professional integrity and to say, okay, this is the line where my job stops and the psychological job starts, and to refer, and the other way around. So patient will be covered, and we're not going to try and cover something that we don't have, the ways to deal with it, because we did not learn psychology, but we do have some behavioral tools, and this helps the patients, because obesity is a complex disease, and this disease affects the behavior, and the behavior affects the disease, so you cannot separate these things.
So it's a complex entity, the disease called obesity. We already you pointed it out that exercise, and of course, exercise and nutrition go hand in hand. Back in the days, and sometimes now even, there's still a stigma on obesity, like, okay, you just need to eat less and exercise more. Some people get advice like, yeah, just go to the gym and work out. What I would like to know, and that's something that could be interesting for our listeners too, in terms of exercise, in terms of nutrition, Yafit, or do you have specific recommendations for patients before and after surgery in terms of exercise and what they need to eat? Because a lot of people, I can imagine, are motivated to change their life, are motivated to go in the gym and lift some weights. But then if we talk about exercise, we also need to talk about protein. Enlighten us. What's your vision? What's your advice?
So we'll start with the protocol, and the recommendations for patients after bariatric surgery is to eat at least 60 grams of protein per day, or another recommendation is 1.1 gram per kilogram of ideal body weight, which is the weight of the person if we would have a BMI of 25. And this is the minimum coverage. The reason for this is that when people lose weight, especially when they lose it rapidly, they also lose lean body mass, which is muscle and skeleton. And when they lose this muscle, this actually affects the way that their body will burn calories, the BMR, what we call the basal metabolic rate, which means that when the person will finish his weight loss, it will be very hard for him to keep his weight. So we want the protein and we want the exercise, especially the resistance exercise, in order to minimize this depletion of muscle mass, and in order for the patients to keep their body metabolic rate as high as possible so they can keep their success after surgery. And protein has also a lot of other advantages like satiety, especially long-term satiety. So these are all things that we work on in the clinic in order to keep the patients not only losing weight, but losing it in a balanced, healthy way. And obesity is not just weight. It is more body composition than it is weight and weight loss.
Okay. Laura, do you agree, or do you have another point of view?
Absolutely. And I think nutrition and physical activity is something that they had to go hand in hand. And in our clinic, we really collaborate with physiotherapy. We have a program that the patient can join, and what we notice is that at the beginning they are a little bit ashamed to go to the gym or to go for a swim. So we try to put the patient in a protect situation at the beginning, and they follow a special physiotherapy physical activity program during 3 to 6 months. And then when they already achieve a good weight loss, they feel comfortable to start to go in the nature to do physical activity.
So basically you protect for the first steps in exercise and fitness, and as soon as they achieve a stable situation, you let them out in the open.
Absolutely.
That's basically what you conclude. We can talk for hours about this topic because it's really interesting. It's dynamic. To close off this podcast, I would like to ask you both one last question. In terms of science, in terms of nutritional science, there is an extensive body of literature assessing vitamin deficiencies after surgery, depending on types of surgery, supplementation, and so on and so on. Few of our well-known colleagues, among Dr. Edo Aerts, Dr. Marieke Smelt, myself, wrote a lot on the topic, among many other colleagues. What kind of thing are you missing in science nowadays? What do we need to investigate in the next few years? And I would like to the answer from both of you. Jafit, can you start?
Well, I think that, and this is an idea that started from Dr. Shirishev Dagan, that we should research the trajectories of weight loss, because we know that there is insufficient weight loss and there is weight regain, and that people react differently to surgery. So I think that researching the trajectories of weight loss after bariatric surgery will be a very empowering data for us, and it will open many new areas, and we can maybe even have the best surgery for the best patients, know who needs pharmacotherapy, who needs surgery, where it's a totally different thing we haven't even discovered. And I think this is our next ideal goal.
Sounds like a good idea. Laura?
Absolutely. I can just agree about that. And what I think what would be for me like interesting is to have some more research about the non-responder. There are really some patients that they don't respond. They can still eat very normal portion. They have no satiety. The loss of weight is not as expected. And I think it's fascinating. Sometimes these patients, they ask, but I really had an operation. Are you sure about that? And it would be interesting to see why there are some patients that are really not responding.
Yeah, that's also a very, very interesting and intriguing concept, because probably we need to look at hormonal effects after types of surgery, maybe even genetics. And that's the reason why obesity is such a complex entity as a disease, and will keep us busy for at least the coming years. I would like to close off this podcast. It was lovely to talk to you both. We haven't even discussed the benefits and the side effects of several types of surgery. So maybe we should do a podcast part 2 on key nutritional aspects after bariatric surgery with a new emphasis. I would like to thank you all for listening. Any last words from both of you?
From my side, obesity is a disease that needs a multi-professional team to take care of.
I think I have the most interesting job in the world, because it combines science and psychology, and I think it's a beautiful profession we all have.
I couldn't agree more. Thank you all for listening, and until the next podcast. Thank you very much.
This podcast was sponsored by WeightWorks Clinics, the Netherlands. Thank you all for listening.